Shoot.
Hello, so my name's Dr. Vinay Gupta. I'm one of the GP partners of Willows Health. We just want to have a little sort of question and answer session about, you've probably guessed it, the coronavirus. So, I mean, I'm assuming everyone is well aware that the World Health Organization has just declared this to be a pandemic. So it's probably the most talked about topic in the world right now, and really how it's affecting us clinicians. So just as a bit of background, we actually had a case over the weekend at one of our practices, and the difference in this case was that the patient involved wasn't or hadn't actually been exposed to any of the nationally recognised risk factors so far. That is either travel to or from one of the high-risk countries, or having been actually exposed to a confirmed case of the coronavirus. This has obviously made us think very carefully about how we need to tackle the issue, because it is suggested, and something that's been corroborated by Public England as well, that there is actually now in the UK an element of community transmission of the disease. So with us, I'm very happy to say we have Professor Mohamed, who is another one of the partners and the directors of Willows Health, and a very experienced clinician. So just on the back of this case, I just want to talk through and get Professor Roshan to explain a little bit about some of the changes that we have made.
Good afternoon, Vinay.
Okay, so I think the main thing that all clinicians and staff and everyone will want to know, as well as our patients, what are the main changes that have been made in terms of patient access to the surgeries?
So I think you introduced it really well. I think that the issue that patients who have no travel history and who may not have a history of being having a contact with a confirmed case of the coronavirus may still be at risk, or indeed actually have the infection, means that we need to protect our patients. So as a result of that protection for patients who are in the surgery and for our healthcare staff, as well as patients who might actually have the virus, what we've done is started a system whereby all patients, before they're seen face to face by a healthcare clinician or by an administration member of staff, will have a telephone consultation or an online consultation with a clinical member of staff. So the clinical member of staff will ascertain what the risk is for that patient to have the virus or not, and then act accordingly.
Okay. And am I right in thinking this has been implemented since the start of this week? So
absolutely. I think we've as you say, acted very quickly. We had the case on Friday. I think on Saturday, one of our partners, Professor Roshan, spoke to Public Health, as well as to one of our partners, Dr. Kapasi as well. And by Saturday, actually had enough telephone conversations. We then had a Cobra-style meeting on Monday, and put it all into implementation straight away.
It sounds like it's obviously been implemented very quickly.
And the good thing is we have at the same time made sure that all the clinical and non-clinical staff are aware of the changes. And I appreciate this video also is one further way of making sure that some of the clinical staff who might not have been able to access the video conference now have a way of doing so.
Fantastic. So sort of moving on to that point, as a clinician, I guess what I would want to know if I'm working one of these practices is how will this actually impact me as a clinician? So, what kind of things should I be asking these patients before they come down?
I think that's a very good question. The biggest difference for you, and I think most of our clinicians are used to the idea of having telephone consultations with patients, and indeed we have in our armatorium a superb online service provided by Dockley, who are also going to be providing consultations to patients. Some people prefer the online method of consultation rather than just telephone ones. But from the telephone point of view, what you're really making sure is that the patients you're speaking to have no risk or very little risk of having a COVID-19 infection. The kind of questions you're going to be asking for clearly will be the travel question, whether they've been to traveling in any high-risk countries, but they will also ask whether they've had a contact with a confirmed case. But as we've just learned, those two questions are no longer need to be positive for you to have the infection. So the other three questions that they will ask is, Has the patient got any respiratory symptoms like a cough or shortness of breath, and have they got a fever? If they've got any two of those three symptoms, they'll be given advice of what to do next.
And I think it leads on perfectly to what advice or other avenues of help can we offer them if we're telling them not to come down to the surgery?
The thing about the COVID-19 virus, as I'm sure you're aware, is that 8 out of 10 people who get the virus, although we can't take it as lightly as the flu virus, will have no more than symptoms of the flu virus. Young people particularly will probably notice they've got a cough, a fever, myalgia, flu-like symptoms for about a week or so, and it'll settle down. The problem is, of course, 20%, the 2 in 10 patients who will actually get worse symptoms. 1 in 20 of them, which is 5%, may actually have such severe symptoms that they're admitted to ICU. The other patients can still have symptoms which are a bit more severe. Both that group of patients will need further care. So the ones with the less severe symptoms will put through to 111 and make sure they're given advice. The ones who are more severe will end up needing to go to hospital via 999.
Okay, so I guess what we're saying is that we've got a couple of different avenues, and hopefully these organisations are also preparing.
We're covering all our bases.
Okay.
Yeah, absolutely.
Fantastic. Just sort of another side point is obviously not everyone is going to present with these symptoms as their primary cause of concern. So say actually their primary cause of concern is something completely different, like leg pain or something else. Why would we still need to screen such patients?
So I think what's been found nationally is that some patients who have been consulted by non-clinical staff have only reported some of the symptoms when they've had the face-to-face consultations with the doctor. And what we do know from previous experiences that doctors are probably the best clinicians to get the right history from the patient.
Okay.
And I think we, again, to have belts and braces to make sure that none or a minimal number of patients get through the screening process. I think we're taking this precaution.
Okay. Sounds very reasonable, to be honest with you. Couple of sort of last things, and you know, one thing that I would certainly want to know as a clinician is obviously that issue of patient and clinical safety. So is this triage going to be unlimited, or is there going to be some kind of limit or cap on it so we can actually ensure clinical safety?
Oh no, I think that's a good question. I'm going to assure all our clinicians that we're not expecting them to do 50 or 100 clinical telephone calls every day and put themselves and patients at risk. The idea is that they will have the right number of consultations. Once they're full, as I say, there are the online consultations available, and we also have other ancillary people available to be able to deal with the patients. So you'll have a limited number of patients. We're also making sure that if once you've spoken to the patient, if you feel the patient needs to be seen face to face, so these are people obviously who don't have the COVID-19 virus risk, that they need to be seen for something else altogether, abdominal pain or whatever, that they have enough room in their clinic and indeed in somebody else's clinic to be able to slot these patients in. So patients who need to be seen will be seen. Patients who are at risk of COVID-19 will be managed appropriately, and the number of cases that each clinician will deal with will be a safe number of patients.
Fantastic. And with some of the other healthcare professionals that you typically will find in practices, such as it might be nurses or healthcare assistants, obviously a large proportion of patients booked into them will be pre-booked, so maybe over the preceding 2 or 3 weeks. How would you go about a similar kind of...
So I think we've been very innovative. We've tried to make sure that our computer systems and our telephone systems are addressing this. We have a telephone message which clearly tells patients what the risk factors are and what the symptoms are to look out for, and make sure they get a clinical triage appointment before they come in. Mm-hmm. The people who've been pre-booked, as you say, are usually booked in for other reasons, but also for them, we're sending a text out to all of them to say, we appreciate you've got an appointment for something which is totally unrelated. However, if you do have the symptoms that we've just spoken about, then please ring the receptionist and get some advice before you come in.
Okay. Thank you very much, Professor Roshan. I think that was very insightful, very, very useful, and particularly for the clinicians. I mean, I think probably it sounds like obviously all the correct changes have been made, and we'll be reviewing this on a very regular basis. Just sort of to finish off, maybe one take-home message for the clinicians where we stand at this point?
I think the biggest take-home message is we're making sure our patients and our clinicians are safe, and we are going to be reviewing this every week and indeed on a daily basis to make sure that whatever changes need to be implemented are done so.
Okay, thank you very much.
Thank you very much.
Thank you.